if you've been here before in previous editions of the Masters, you've seen me talking about the rare diseases, and it's not going to be different today. But today I'm going to share with you some updates on congenital ichthyosis. So my disclosures here, I am PI in a trial that I'm going to mention in one of my slides here. And all those therapies pretty much are either off-label or experimental treatments, because it's really all there is for ichthyosis at this point. So as you know, what ichthyosis have in common is the abnormal differentiation of the keratinocytes and desquamation that leads to that scaly skin that we're all familiar with. And there's also defects on the epidermal permeability that we see across the spectrum of different types of ichthyosis. It is a very large group of diseases with a lot of variability. Those tables I took from Dr. Schechner's textbook. And you can see here the most common types of ichthyosis. You can probably not see this, but this is just to show you how there's so many types of ichthyosis. They're broken down here by mode of inheritance, syndromic and non-syndromic types. And this is just to exemplify that we're dealing with a family of very many different diseases. And even though they're very different diseases, we haven't been managing them up to now quite similarly with just some general measures. So what we have been doing so far is treating most of those patients with emollients, doing measures to facilitate the desquamation, whether it's baking soda baths or using topical keratolytics, systemic or topical retinoids. We've been treating the skin comorbidities that come in association with it, namely atopic dermatitis, superimposed infections. We've been managing symptoms like pruritus and giving patients nutritional and psychosocial support. So we've been doing this to all kinds of ichthyosis, which is obviously helpful, but not sufficient for our patients. And this is a very interesting picture I found in one of the papers I was reading when I was putting this talk together that just goes over how we're shifting the paradigm on the treatment of ichthyosis. So as you can see here, there's a lot of preclinical and clinical studies looking into very different ways of approaching ichthyosis, whether it's with development of small molecules, replacement therapy, gene therapy, which I think is the most exciting of all, or by simply repurposing drugs that we have been using for other purposes at the moment. So I'm going to go over some types of ichthyosis, either because they're really common and I feel like we need to be familiar, need to know about them, or because there's some new and exciting treatments coming up for those. So first, I'm going to talk about ichthyosis vulgaris, and I think a lot of us have seen that in our clinics. It's not that rare, so it's important that we know exactly what we're dealing with. And what happens here is that those patients are going to have loss of function mutation on the filaggrin gene. And if you look at this laundry list I put here, this is all that happens on your skin when you don't produce a functioning filaggrin molecule. And you can see how that relates with the skin being dry, the increased transepidermal water loss, the skin being scaly, and then that propensity to atopy that we see in these patients as well. So here's what we see on those patients. So we see some degree of keratoderma and hyperlinearity on the palms and the soles. We see keratosis pilaris. We see scale that sometimes can be limited to the lower legs, but it can be more widespread and affect other parts of the body, but typically spares the folds, spares the face as well. Most recently, it has been described that those patients can have some hyperkeratosis on the dorsal portion of the fingers as well, which can be a little bit more sudden. Not everybody picks up on that. And those patients can have hypohidrosis as well. And of course, like we know, they have an increased propensity for atopic disease. And unfortunately, there's nothing new and exciting with ichthyosis vulgaris, but I just put it here so we're all aware and we all know how to diagnose this. Second, I'm going to talk about the second most common type, which is X-linked recessive ichthyosis. And this happens because of mutations in the sterosulfatase gene, which participate in the metabolism of cholesterol and steroids in the body and can have other functions as well. And that's why we see that those babies are usually born up after prolonged labor, and we should look for other things like cryptorchidism and eye changes on them as well. So what we see here on those kids, mostly boys, is that dark brown sort of stuck-on scale it's very pronounced on the trunk. There's this classic presentation on the sides of the neck, on the preauricular skin. That's what people call the dirty neck, which is really a terrible name. And maybe Dr. Siegfried can come up with a better name for this since you're so good at naming things. And here we also see a sparing of the central face, sparing of the folds, like you can see in the picture. We don't see the keratosis pilaris, which might help you differentiate this from ichthyosis vulgaris. And when females are carriers, they can present with a very mild phenotype, namely with some more fine scales on the lower legs. And what we have of novelty here for X-linked recessive ichthyosis is this phase 3 trial that's active and recruiting right now, that's looking at the topical formulation of isotretinoin as an alternative to the systemic isotretinoin in these patients. And so far, the data that we have from the phase 2 and previous phases is that it can be very efficacious. There's minimal systemic absorption and is overall well tolerated on those kids. But we have more coming soon, hopefully. For the congenital, autosomal recessive congenital ichthyosis, I chose to talk a little bit about lamellar ichthyosis. And like Dr. Bruckner just showed us now, those are babies that can be born with that colloidal membrane that we saw in her photos. But then later on, they progress to variable degrees of erythroderma in the body. Typically, we see some more of that during childhood, not so much in the adult years. But the common presentation is that they're all going to have those very large, plate-like, brownish scales diffusely throughout the body, including the face, like you can see here, as well as some ectropium, eclabium, scarring alopecia, that's very common. And we see this with the mutation in the transglutaminase 1 gene, like she showed us before as well. And the exciting finding here is that there is gene therapy in development to fix this defect in the TGM1 gene. So this is a product that's applied topically. It's in preclinical phase still, but we're hoping to see the clinical trial starting soon. And what is done here is that HSV vectors who have the ability to enter keratinocytes, they contain a fixed form of the TGM1 gene, and once they enter those deficient keratinocytes, they're able to restore the function and the production of TGM1. So more to come on this, hopefully in the next couple of years, but pretty exciting. And to wrap this up, I'm going to talk about one of the syndromic ichthyosis, which is Netherton syndrome, and Dr. Bruckner touched on that a little bit too. Here, we see that those mutations on the SPINK5 gene, which are present in different parts of the body and account for differentiation and shedding of the stratum corneum, have a role in the hair growth as well, and also participate in anti-inflammatory, antibacterial processes, or presence in the thymus. That's the mutation that we see here. And those patients can present in a couple of different ways. You can see that colloidal membrane as well when those babies are born, but as they grow, they might have a phenotype of more of a diffuse erythroderma, diffusely red, scaly presentation, or they might show up more like the picture you see below here with what we call ichthyosis linearis circumflexa, which are those polycyclic patches where you see on the edges that double scale that you see pictured here on the bottom. In addition to that, there's a very characteristic hair finding, which in very young babies we find first on the eyebrows, and later on you can find on the hair. That's called trichorexis invaginata, or bamboo hair, and that's what you're seeing pictured here on the top. And remember that those babies are likely to develop atopic diastasis, the full spectrum of atopic disease, and they are more susceptible to infection as well. What I want to show here is this interesting work that gathered information from a series of patients that have both the scaly erythroderma phenotype and also the ichthyosis linearis circumflexa phenotype. And through analysis of both the blood and the skin samples through a series of different techniques, found that both phenotypes actually have an IL-17 and IL-36 signature, which we didn't know about before. And when you isolate the ichthyosis linearis circumflexa patients, those have a more of a Th2 response, more accentuation of that. And the patients who have the scaly erythroderma more diffusely, they have more of an interferon profile as well. So by learning this, that helped explain a little bit why so many of the therapies that we use in general for ichthyosis weren't so effective for Netherton syndrome. So what you're seeing here in red is therapies that actually cause worsening on Netherton patients. In purple, when there was no improvement but no worsening as well, and then in teal, when there was only improvement on our patients. And if you notice here on the top, the retinoids, which we use for so many types, actually, some of them cause more worsening than good for our netherton patients. And that helps explain why some out-of-the-box therapies like IL-17 inhibitors, dupilumab, often show a little bit more benefit for those patients. And to wrap this up, I'm just going to show you some examples of what I'm talking about here. So this is, excuse me, a patient with Netherton syndrome who was treated with secukinumab. And you can see here on the top, prior to treatment, and a week after her first dose of secukinumab, how there's a marked decrease in the erythema and on the scales as well. And here, another case treated with dupilumab, and you see on the sequence week 0, week 4, week 10, significant improvement on the scale, erythema on the skin as well. And along with that, there was an improvement on the bamboo hairs. So you notice the difference between the length of the hair and then on the trichoscopy, the resolution actually of some of the bamboo hair. So to summarize, ichthyosis are a great family of diseases. We're very different. There's a lot of variability on the presentations, a lot of variability on the genetic backgrounds. And as we learn more about those genetic backgrounds, we're hopefully going to be able to come with more targeted, more effective therapies and the general measures that we used to do before for those patients. With that, I end. Thank you.
All right. Well, great. Yes, okay, so I have to just warn you, so EB has really kind of been my career-long passion, and I could probably talk up here for a long time, so just cut me off after 15 minutes if you need to. I have had several, I think this is actually a great time to be learning about EB because, there really has been this burgeoning in terms of interest in developing better therapies for EB, and so many of my conflicts of interest do relate to either being researcher or advisor for several companies, so just keep that in mind. Okay, so we're going to be, well, let's just kind of dive in. So, EB has sometimes been described as the worst disease you've never heard of. And I think this is really apt because this is a rare condition, first of all, and when kids are diagnosed with severe forms of EB, they really, are basically committed right now to a lifetime of care that can be very painful, and it's really kind of psychologically traumatizing, not just for the child, but for the family as well. As I mentioned before, it is not just one particular diagnosis. There is a whole range of different disorders with EB, and the prognosis can really vary. So in terms of how we classify this, the classic classification has been based on where you see splits or blisters forming at the microscopic or ultrastructural level. And so whether or not that's in the epidermis, those are forms of EB simplex. When it occurs kind of at where the epidermis and the dermis join together, that's called junctional EB. And when the blistering is in the superficial dermis, that's called dystrophic EB. There's also this rare disorder called Kindler syndrome or Kindler EB, where you kind of get a mix of different blisters forming. There is a consensus statement on classification, and it was published in 2020 in the British Journal of Dermatology. This is actually, it's a great resource that kind of goes through a nice review of the different types of EB. And so this slide really is just kind of meant to highlight, again, some of the heterogeneity that we see in EB based on the diagnosis that you see here. And so if we're kind of going around the circle counterclockwise, we see pictures of EB simplex. In some forms, EB simplex can be very localized. It involves just the hands and the feet. There are more extensive forms of EB simplex where the blisters form in groups. That's what we now call the generalized severe form of EB simplex. We also have some examples of junctional EB, and as I mentioned in the last talk, sometimes this is not very impressive at birth. But unfortunately, in the worst form of junctional EB, the children will go on to develop failure to thrive, high risk for infections, respiratory involvement, and most of those children will pass away within the first year of life. All the pictures that are on the right side of the slide are showing different manifestations of recessive dystrophic EB. And this is an area where there's a lot of emphasis on therapy right now. This is a disorder due to an absence or deficiency of collagen 7, which is an important structural protein in the skin. Again, these babies can be born with widespread erosions, blisters, and areas of trauma. This heals with scarring over time, and so you get scarring not just in the skin, but involving mucous membranes, which is why the mouth is small. That also occurs in the GI tract, which leads to what are called strictures in the esophagus. And the picture at the very bottom is showing this devastating complication of RDEB, which is the development of squamous cell carcinomas, which can be very aggressive in these patients. And data suggests that once patients have been diagnosed with squamous cell, in most cases, they will end up passing away within the next 5 years. So again, this is, it just can be incredibly devastating. It is important to keep in mind, though, even though we often will talk about EB as a skin disorder, I really think about it as a multi-system disorder, especially when we're talking about junctional EB and dystrophic EB. These patients, in addition to the skin and mucous membrane involvement, have lots of, we talked about the higher nutritional needs. This can be reflected in poor growth, anemia, multiple nutritional deficiencies. We also know that they can have higher risk for osteoporosis and osteopenia. And the symptoms of pain and itching are also very disabling to patients, and so that's really important to keep in mind. So that being said, I think that really in my opinion, the best way to approach the care of patients with EB is to really kind of think about a village or a family of specialists that are going to be helping you to take care of your patients. We have a multidisciplinary EB clinic at my institution, which meets 1 to 2 times per month to see these patients. We focus obviously on things such as wound care. The goals of wound care are going to be to minimize the development of new blisters in the skin, but also to optimize the healing that's going on. What will happen with many patients with EB is that initially the blisters and the wounds, they often will describe that they open and close, but unfortunately many of the wounds in patients with EB over time will become chronic open wounds, which can be very painful and uncomfortable. As I mentioned before, though, nutrition also super important. You are not going to actually heal wounds without having optimal nutrition. And so the nutrition and the wound care really kind of go hand in hand, and obviously our patients for the most part are children. They need nutrition in order to grow as well, and so that's really important. We do a lot of kind of just monitoring as well, lab work to make sure that these patients aren't anemic, looking at other things as well with lab work every 6 to 12 months, depending on the severity of the condition. And I've certainly touched on this before. The psychosocial support is super important. At this time, unfortunately, there are no approved treatments for EB. I am very hopeful that will be changing this year, but as of today, there are no approved treatments for EB here in the U.S. And that really just, I think, kind of highlights that there is a huge unmet need for therapies for these patients. Okay, so let's kind of dive in a little bit deeper on some of these things. Wound care. So as I mentioned, the goals of wound care are going to be to accelerate healing, but also we can think about wound care as a way to help minimize the development of new blisters. We're not going to prevent all new blisters from happening, but if we can minimize them, that's great. This is an older picture that I have here that I obtained actually a long time ago from one of my mentors, and I think it's a good teaching example for a variety of reasons. We can see that this baby has some blisters, and when we take care of the skin in EB, we actually want to drain new blisters. That's something that we teach families, to drain blisters when they come up, because if you don't, they basically kind of tend to spread out and get larger over time. We're going to be using non-adherent dressings on these areas of open skin. But it's also very important that we remember we do not want to use tapes or adhesives on the skin of patients with EB. Basically, when you remove those tapes and adhesives, it ends up creating more wounds, and this is really important. And anytime your kid's coming into the hospital, you want to make sure that they have the right products that are not going to be causing more trauma on their skin. So how do we drain blisters? You can do this either with using a needle, lancet. Some families will even use small scissors if they get used to doing that. But the idea basically is that, kind of along the lateral edge of the blister, you want to make a small puncture or slit, and then use a gauze to wick the fluid out of the blister. I mean, I could spend hours talking about just wound care in EB. The key concepts are really that, what goes in contact with the skin is something that should be non-adherent. And so most of the products that we're actually using in contact with the skin are impregnated with or made with silicone, which has a tackiness, but is also hydrophobic, so it will release from the skin when the dressing gets wet. This is actually, I think, revolutionized care, for patients with EB. But getting these dressings, unfortunately, they're expensive. It often requires working with a DME company and renewing their orders periodically. So we want to keep that in mind, that what's in contact with the skin is non-adherent. But we use dressings on top of that then to help absorb the moisture. And things like elastic bandages to kind of hold things in place. I did quickly want to touch on a product that has been approved in Europe. This is called Oleogel, or Filsuvez, by Amrit, and the Amrit reps are here, and it would be great if you want to stop by and talk with them. I was involved as an investigator in the phase 3 study of this medication. Basically, the active ingredient here, Oleogel S10, is derived from the bark of the birch tree, and it contains what are called triterpenes, which have anti-inflammatory and pro-cell migratory effects. It's formulated more or less into a gel and topically applied basically to all wounds. And so in the phase 3 study, patients, for the most part, with junctional or dystrophic EB were randomized. Target wounds were evaluated over the course of 90 days. The primary outcome, more or less, was looking at whether or not the wound had closed. The primary target wound had closed by 45 days. And patients did have the option to then go into an open label extension study as well. The gist of this is that, if we were looking at whether or not that primary target wound had closed within 45 days, you can see that for patients who received the treatment, there was a higher proportion of patients with wound closure within the first 45 days. And if you look at the sub-analysis of patients with recessive dystrophic EB, I mean, the proportion of patients who had primary wound closure within that time frame was actually even higher. So it is important to remember, I mean, that this is not a disease-modifying therapy. The intention is that this is something that can be used as an adjunct to the patient's wound care. But I think the upshot of this, that's been kind of shown in some of the more long-term data with this study, is that it can reduce the frequency of dressing changes and the time that it takes to do dressing changes. And so I think that this is something that could certainly contribute to better quality of life for our patients as part of their routine wound care. As I had alluded to, our patients with EB are at very high risk for nutritional complications. This in part is because they have such high needs for nutrition, but also it's very hard for them to adequately get enough nutrition. The blisters that they get in their mouths makes it hard to eat. Again, they can also have the narrowing in the esophagus, which makes it difficult to swallow. And it's very likely that many of these patients also have absorption and other issues that really just means they don't utilize their nutrients as well as they should. So they kind of have this double whammy going on. Very important to involve a nutritionist, I think, in the care of these patients. When you're diagnosing a newborn with EB, it's really important that you actually start being proactive with supplementing with extra calories right away, in my opinion. So fortifying the formula or the breast milk, making sure that they're getting, the right combination of different vitamins, et cetera, monitoring their growth very closely. And then, as I mentioned, we routinely are checking labs on these patients at regular intervals to kind of monitor some of the very critical vitamins and other things to make sure our patients are getting enough. This is some data that we had reported from a large cohort of patients in North America with EB, just kind of describing, when are we putting in G-tubes, or when are our patients first getting esophageal dilations? And you can actually see here that there are a good number of patients who get G-tubes fairly early on in the course of their illness, and this is actually really important. I mean, getting a G-tube is not a failure for these patients. It's actually very helpful in terms of getting them the nutrition that they need, providing a way for them to take the medications so that they're not having to do everything by mouth. And the graph A is also showing that, for many of these patients with recessive dystrophic, they're developing strictures fairly early in life, and so they're going to need to kind of start getting dilations as early as like 2 years of age or so to kind of keep the esophagus open so that they can continue to eat. I've talked about, addressing symptoms. This is a radiograph showing what patients perceive as important. And really, if you're kind of looking at the red line, which is patients with recessive dystrophic EB, the highest scores are really kind of correlating with things like improving pain, improving itching, improving wound care. So I think that that's really important to keep in mind. I'm going to move on here. I mean, I think ultimately what we would like to see are that, we have a treatment that actually modifies the course of disease for our patients, whether or not that's coming through protein replacement therapy or gene therapy. There are a variety of different gene therapy approaches that have been looked at. What is commonly used is what's called the ex vivo approach, where a patient's skin is biopsied, and then in a lab, the gene is either reintroduced to cells or using techniques to modify the gene, that's done. But then basically you grow those cells back and give them back to the patient. This was first done in an individual with junctional EB, the non-lethal type. And this was many, many years ago, done in Italy, but kind of showing that you can treat a patch of skin and actually leads to great long-term remission of the condition. You might have also heard about this boy. Also in Europe, same group of investigators. This child had widespread loss of skin, like 70% loss of skin, extremely distressing, but had biopsy taken, the genetic mutation corrected, many series of skin transplants done in the course of admission to a burn unit. But really, this led to life-changing resolution of this widespread skin disease for this patient. This is still, certainly being studied in Europe. Similar approach has been taken to correct recessive dystrophic EB, and this is data from Stanford. I'm going to just kind of move through this pretty quickly, but again, kind of using corrected epidermal keratinocyte grafts, showing that you can graft them back onto the wounds, and this leads to improvement in many wounds over time. This is certainly a lot of work, though. I mean, it requires a biopsy. It requires several months to grow those cells and then give them back to the patient. Crystal is taking another approach, and Dr. Fernanda Schmidt had just recently talked about this in regards to the ichthyoses. But what I think Crystal has basically shown is that we can use an inactive HSV vector, more or less, as a way to deliver genes back to the skin. And so in their preliminary work, they showed that if we use that vector to give back the collagen 7A1 gene, it corrects both the keratinocytes and the fibroblasts. That's a topical product that's applied to the skin. I think what's really interesting here is that in the blue graph, this is kind of looking at wounds. Do they open and close over time? And that's what you kind of see in patients who had a placebo used on their wounds. When they get the Crystal product, more or less the wounds close and they stay closed. And you can see that that's also correlating with expression of collagen 7 in the skin. They've recently published results from a phase 3 study. This was published in the New England Journal of Medicine, and again, kind of showing that in wounds that are treated with the BVEC product, the majority of them are more or less staying closed after 6 months of treatment, which is great. So, okay, Dr. Schachner's coming to take me off. Let me just kind of, last thing, I mean, there are many resources that are helpful in terms of managing your EB. Go to Deborah International and search for clinical practice guidelines. There are very thorough recommendations on all of these topics there, and it's a great resource to help you manage your patients. Thank you very much.
Thanks so much, Dr. Bruckner, for a wonderful discussion of a really difficult to treat condition. Probably the pediatric dermatologist's biggest nightmare, and at least progress is being made. Our next speaker is Dr. Andrea Matarral. Dr. Matarral is a graduate of both the University of Miami Medical School and of our dermatology program. Even as a chief resident, we recognize Dr. Matarral as someone who never flinched from any severe disorder, always wanted to try to handle the most complex medical dermatology. So it's not surprising that at this still early point in her career, she directs our autoimmune connective tissue clinic as well as our Hansen's disease program. And yes, maybe over 100 cases of Hansen's are followed at Jackson Memorial. She's also become Director of Medical Student Education. I'm really pleased to have Dr. Matarel back at the Masters, and she's going to talk about morphia and how it behaves.
Thank you so much for having me here today. For the purpose of the talk, I'm going to do a brief overview of morphia, some of the clinical characteristics and treatment, and then focus really on sort of the long-term behavior, what counseling we should give our patients, and what we should anticipate. I have no relevant financial disclosures. I will be discussing some medications off-label. So morphia is one of the more common autoimmune fibrosing disorders of the skin and underlying structures that we see in the pediatric population, and often also goes by the name of localized scleroderma, though I'm not in favor of this designation. It tends to give patients a bad idea of what they're dealing with and some confusion over whether or not they have true scleroderma or systemic sclerosis, so I prefer to just refer to it as morphia. And in this condition, this inflammation and sclerosis causes permanent damage of the skin and soft tissue, and this is particularly disabling and debilitating for our patients because of the long-term consequences: hair loss, cutaneous soft tissue and bony atrophy, joint contractures, and then also when involving the extremities, growth restriction of the affected body site in children. Thankfully, it's overall quite rare, so 1 to 3 cases in 100,000. Its mean age of onset between 7 and 8 years old, and similar to some of our other autoimmune diseases, more common in girls than in boys. Our pathogenesis is overall unknown, but it's thought to be due to dysregulated immune and fibrotic pathways. For the purpose of time, I'm not going to go into too much detail here, but I do want to highlight some of the important cytokines. So interferon gamma, not alpha or beta, which we'll talk about with some of our other collagen vascular diseases later in the afternoon, but gamma here is strongly implicated in the pathogenesis of morphia and may be a potential target for therapy in the future. And then also there's a role for IL-4 and 13 pathways, as well as the JAK-STAT pathway. So again, some things that we may be able to target in the future. And we know that there's this strong autoimmune component. About 10 to 30% of patients will have a family history of autoimmune disease, and we know that about 10% of the children will have other concomitant autoimmune diseases. So for clinical presentation, our classic presentation is first going to start off with those pink or violaceous inflammatory phase that then progresses to the more sclerotic phase, where we're going to see that white sclerotic central patch, but still inactive disease with the surrounding violaceous or lilac border, and then ultimately leading to our more burnt out, hyperpigmented, atrophic plaque of inactive morphia. And we do have subtypes that will progress directly from that active inflammatory phase straight to our burnt out hyperpigmented phase in those atrophoderma variants, so skipping that mid-sclerotic phase. And there are various subtypes of morphia, and there's multiple different criteria or classification systems. Probably the most widely recognized is the Padua criteria, where we break it into 5 main subtypes. So we have the circumscribed or plaque type. This is most common in adults, the most common variant in adults, where we have both superficial and deep forms. Deep also referred to sometimes as morphia profunda or subcutaneous morphia. Then we have the linear subtype, which is the most common one that we're going to see in kids. We have 2 main areas of involvement. So we have craniofacial linear morphia, which includes oncutisab, so with paramedium forehead and or frontal scalp involvement, and then Perry-Romberg syndrome, where we maybe won't have as much overlying skin changes, but have that very striking subcutaneous atrophy or unilateral subcutaneous atrophy. Remember, it's very common to see both features in one kid. So if you see oncutisab, you want to be looking for Perry-Romberg and vice versa. And then we can have truncal involvement that leads to those striking limb length discrepancies as well as joint contractures. We have generalized morphia, where we have 4 or more plaques, 3 or more centimeters in size, and 2 or more anatomic sites, so 4, 3, 2. And then the least common, which is the pansclerotic, where we get these circumferential lesions that will be bound down to the subcutaneous tissue, the muscle and bone. So this is a very, very disabling variant of morphia. And our last one is just mixed. So when there's 2 or more subtypes present in a patient, then we have mixed morphia. And extracutaneous manifestations are common in kids, so we see it between 46 and 74%. The most common are going to be the musculoskeletal manifestations, articular disease, and in particular in our generalized morphia patients, they can have inflammatory arthritis. Neurologic, we really worry about with that craniofacial linear morphia. And they can present with various features, migraines, seizures. And in these craniofacial linear morphia patients, we also worry about ophthalmic and oral complications. But we can have a whole host of other nonspecific manifestations, such as fatigue. As well, we can see Raynaud's phenomenon. And diagnosis. So the most important thing that we can do for a morphia patient is making a timely diagnosis. We know that in a lot of kids, it can be delayed, usually more than 6 months from the onset, and we'll talk about why it's so important that we diagnose them early and get started on therapy soon. And though we can make the diagnosis often clinically, we do typically perform biopsies to help confirm the diagnosis or to exclude other diagnoses, looking for that fibrosis, which can be what's referred to as top-heavy morphia when it's a little bit more superficial, or we can see bottom-heavy morphia, which is going to see in more aggressive variants that can be associated with more pain and more challenging to treat. So some additional workup we want to consider for our craniofacial morphia patients. We do generally get MRIs, though the role is a little bit controversial. Our MRI findings don't necessarily mimic the symptoms, and vice versa. Patients can have symptoms with a negative MRI, or they may have very striking MRI findings with absence of symptoms. But we do generally get brain MRIs for these kids, as well as dental assessments and uveitis screening. And then for kids who do have deep morphia, we want to be getting MRIs. We don't need this necessarily just for confirmation of diagnosis, but really for monitoring the extent of their disease and monitoring their response to therapy. When they do have that deep fascial involvement, MRI is going to be very helpful here. And then when it comes to treatment, the first thing that we have to establish is the extent of their disease. And we do this through clinical monitoring. There's various tools that have been utilized both for morphia and for scleroderma. Listed below, but the one that's been probably the most validated in the pediatric population is going to be the Localized Scleroderma Cutaneous Assessment Tool, abbreviated the LOSCAT. Here, it's able to take into account both markers of skin disease activity, so looking at if they have new or enlarging plaques, erythema, and skin thickness, and then also looking at damage. So it takes into control both elements, so we're really able to assess the degree of their disease very well, and we can trend these scores over time as a response to their treatments. Some other things that are not so readily available in terms of accessibility are Doppler ultrasound. This is actually a really cool technology where they're not only able to assess how thick the lesions are, but they can also evaluate for activity and inflammation by looking at the vascularity of the lesions. But this is something you have to be very well skilled in performing, so it can only be done by certain technicians, and also is very, very time consuming, so not really practical for everyday practice, but maybe something that could be more available in the future, as well as durometry, again, being able to assess the thickness of the skin, but again, this isn't so widely available, and then MRI for our deep morphia. So now that we've been able to establish their extent of disease, we have a good score available to them. Now it's time to initiate therapy. And for kids who have more superficial circumscribed morphia, we can do that with local therapy. It's appropriate if not involving joints or cosmetically sensitive areas. And we use high-potency topical steroids, intralesional steroids, as well as several steroid-sparing therapies like tacrolimus, calcipotriene, and imiquimod. For kids who have more generalized dermal involvement, or if they're rapidly progressing, we can do phototherapy, both narrowband or UVA1, though there has been some superiority demonstrated with UVA1 phototherapy over narrowband. Because of less access to UVA1, we do traditionally use narrowband UVB, and important to always counsel them that phototherapy should be done together with topicals. So there is data to show that doing topical therapy plus phototherapy is superior to phototherapy alone. But for our kids who have more deep circumscribed morphia, linear morphia, generalized, pansclerotic, or lesions that may impact function or cosmesis, or are more severe morphia patients, we really need to be treating them with systemic therapy. And our first line remains oral therapy, oral steroids together with methotrexate. So a systematic review done in 2018 compared methotrexate and phototherapy, and though both of these were effective in morphia, the efficacy rates you can see were higher for methotrexate. And when there was a multi-center double-blind randomized control trial of 70 pediatric patients who were randomized either to prednisone monotherapy for 3 months or that together with methotrexate for 12 months, they found that relapse rates were significantly lower for our methotrexate-treated children as compared to the prednisone-only group. So this highlights the importance of not only steroid-sparing therapy together with it, but for prolonged periods of time after they've completed their prednisone. For kids who are either intolerant of methotrexate or are refractory, we generally will use mycophenolate mofetil. You can see very high response rates there. Over 90% of kids had sustained remission with mycophenolate mofetil after an average follow-up of 9.4 years. And there are several other options listed there. I just wanted to show this recent case report that I thought was really striking. This is an adult population, but the top patient has eosinophilic fasciitis, and the bottom one, generalized morphia. They were treated with JAK inhibitor therapy, and I think the results there are really quite impressive for two very challenging diseases. So again, targeting that JAK-STAT pathway, which has been shown to be involved in the pathogenesis of morphia. So prognosis, I mentioned we were going to talk about long-term outcomes, and this is really important for us to appropriately counsel not only, of course, our patients, but their families, that this is a long disease. So it tends to last a very long time with a duration between 5 and 10 years. Some subtypes, such as the circumscribed subtype, has a shorter course of duration, so it can spontaneously remit for 3 to 5 years. But this is really something that's going to take a long time. And this is a really nice study that was published. They looked at their cohort of morphia patients, followed them over 10 years of time. And just to give you a general idea, the red is going to be active disease, blue partial remission, and green complete remission. If you look at 5 years, you can see that only about 50% of kids were at complete remission. So 5 years after they were diagnosed, only about half of the kids are going to be at complete remission. And at more than 10 years, there were even still some kids who had active disease or partial remission. And this is because of the course that morphia tends to follow. So it follows this relapsing, remitting course. Here again is looking at a cohort of 126 pediatric morphia patients where they looked at those who had responded and not responded to therapy. You can see that the majority, so 81% of the total pool of kids had responded to therapy, but a high percentage had relapsed after primary treatment. Most of those, when they were retreated, responded again. However, again, another 13% had relapsed after their secondary treatment. So it really follows this, this relapsing remitting course. And who is it that we're going to be more concerned about relapses? Well, anyone who there's a delay in initiation of treatment. Again, that's why we want to make that diagnosis early and we want to get treatment started soon. Certain subtypes, so linear, deep, or generalized, are more at risk of relapsing. If they have a positive anti-nuclear antibody. And then age of onset, there's actually mixed data, some studies showing that earlier age of onset is associated with higher risk of relapse, and then others showing the adolescent population having a higher risk of relapse, potentially related to poor compliance. Interestingly enough, when they've looked at various initial treatment regimens, so if they were started with phototherapy, topical therapies, or systemic therapies, and if there was a difference in the risk of relapse, they actually did not find that, but that likely is because more severe patients are going to be treated with systemic therapy and more aggressive therapies. And there is some data to suggest that longer methotrexate courses may help to reduce that risk of relapse. So one of the most important things that I got to learn from my wonderful mentor, Dr. Schachner, is we never say goodbye to our morphia patients, even when they're doing well and when we have them off of systemic therapy. We want to let them know that we are here for them and we want to continue to see them. And in particular, for the linear or generalized subtypes, we really should be following them every few months for several years after they are off therapy to look for signs of relapse. Lastly, I just wanted to highlight that not only are we concerned for this relapsing remitting course, the need for initiation of reinitiation of therapy, we also have to take into account the long-term damage that occurs with morphia. We saw with some of the subtypes, in particular linear with craniofacial involvement, pansclerotic, and any subtype involving the face, they can have a lot of damage. What's interesting, though, is that this damage tends to happen early on. So here's looking at a cohort of morphia patients and their damage scores, and you can see that the breakdown between severe damage and more mild damage really didn't change considerably after the first 2 years when looking at greater than 10 years. So the majority of damage is really happening early in the course of their disease. And there are things that we can do to improve their damage. So we can do things like dermal fillers and fat transfer if they have significant atrophy. But of course, this is only when the disease is really well controlled on immunosuppressives, or I prefer for them to be quiescent off therapy before initiating these therapies, but that is an option for them. And for our subtypes who maybe don't have quite as much of that subcutaneous atrophy and more have pigmentary issues, there is a role for lasers, both some lasers being used actually for active disease like excimer laser and pulse dye laser, but then other lasers, more of our fractional lasers, being used to help with the dyspigmentation that we can see as a consequence of the morphia. So on the right, a child who was treated with CO2 laser, and you can see really impressive results. And so with that, I want to thank you all for your attention.